Good day, ladies and gentlemen, and welcome to the SPSP Medicines Reducing Medicine's Harm Across Transitions conference call. My name is Mara, and I will be your operator for today. At this time, all participants are in listen-only mode. Later, we will conduct a question-and-answer session. If at any time you require operator assistance, please press *0, and we will be happy to assist you. And now, I would like to turn the call over to David Maxwell. Please proceed.
Thank you very much, and welcome everybody to what is our second last WebEx for the year, focusing on reducing medicine's harm across transitions. And it's fantastic this afternoon that we've got NHS Highland, who are our guest boards, presenting this afternoon. For just a bit of history, we actually tested this model at the end of 2015, and NHS Highland were gratefully one of our test boards to really see how we would go about sharing reducing medicine's harm across transitions work within a WebEx situation, looking at the whole system at a board perspective. So it's great to have Highland presenting again outside of that test zone, and we're really looking forward to hearing from them today. So as mentioned, all of the participant lines are purposely on mute at the moment, and that's just to allow make sure that we've got a clear presentation from our guest presenters, but we will be opening the lines later on to actually allow some discussion between both the participants and the presenters. So as we progress through, please make sure that we are using the chat box, and I can see that people are introducing themselves, and that's fantastic. So if you haven't introduced yourselves yet, please do. Just let us know who you are, where you work, and perhaps what your role is. But the aim of this WebEx series has been for the whole year to really support the learning and sharing between boards around medication reconciliation as a whole system. And we're really wanting to think about, at a board level and also in the unit level, what's our theory for improvement, and really try to focus on what tests of change have really resulted in that improvement. And I think it's fair to say we're going to hear some fairly honest reflections around the progress to date in Highland and what's actually happening in terms of the next steps for them. In terms of our WebEx etiquette, we've already automatically muted your phone, so we're not necessarily hoping to hear from you until we actually open them later on. But we do really want people to be open to learning and sharing. We do want people to use the chat box, and as I've seen, we've got some people using it already. And rest assured, if you've got any burning questions, please throw them into the chat box. And Catherine's here monitoring the chat box throughout the WebEx, but we'll also give you an opportunity to actually speak on the call once we've actually heard from the board today. So for those who aren't too sure, please press the chat icon box, which is in the top right-hand corner of your screen, and do make sure that you press all participants, in the fact that we would love to make sure that we're speaking to everybody on the call. I have received some lovely private messages in the past that I'm sure were intended for everybody, so please do make sure that you do select all participants from that drop-down menu. So we did a survey, and again, I think most of the people are aware on this call of the fact that we evaluated our WebEx series earlier, probably about 2 months ago. And one of the asks was to really focus on our improvement theory. So again, we've got a driver diagram that's been mapped out for medicine's reconciliation across the whole system that's freely available on the NSPSP website. And really to focus on what kind of drivers do we think our improvement activity is focusing on, and maybe reflect, as we hear from NHS Highland, whether the primary drivers are addressing some of the issues associated with person-centred care, leadership and culture. Perhaps it's focusing on improvements to do with teamwork, communication and collaboration. Maybe it's about the safe and effective, reliable care being delivered to every patient every time. Or perhaps there's a need to focus on improvements relating to systems and IT infrastructure. So again, we're really keen to make sure that we focus on our theory for improvement and to see how we can actually use data to drive improvement and actually make medicine's reconciliation a safer and more reliable process. So as I've mentioned, this is our second last WebEx for the year, and we've, from the previous 3 WebExes, and unfortunately I personally wasn't available to attend the WebEx in October, but I hear that it was a fantastic time to hear from both NHS Orkney and Shetland. And we already know, and we'll always reiterate the fact there's a great understanding that medicine's reconciliation is an extremely complex clinical process. And I think it's fair to say now, it's not just senior medical engagement that's really needed. We really are requiring and learning from boards that it's senior multidisciplinary team engagement to be ensuring success, particularly in the acute care setting. And what we did learn from the 2 boards that presented last month They've presented some honest challenges around some difficulties engaging in locum doctors in the medicines reconciliation process. They also shared around their experience of communication between primary and secondary care and the importance of integrated team working. So I'm really, really excited again, the fact that we've got Highlands back today to really build on some of the things they shared with us in the testing period, which is just over 12 months ago. Before I hand over to Highlands, I can just see in the call that there's one of our participants, Andrew, has just noted that they can't see the chat box. So if you might press *0 and you'll be able to get some help from our host today. But without further ado, can I hand over to our colleagues in NHS Highland, and I'll get them to introduce themselves as they progress through their presentation today.
Thanks, David. My name's Ian Rudd. I'm the Director of Pharmacy in NHS Highland. I'm a Fellow of the SPSP program, and I've been involved within the SPSP work for, well, really since its inception and just as it was getting started. So these are really my reflections on where we are. My principal interest has been in the acute adult program. We also did some work as an early pilot for the work in primary care, i.e. general practice, and Claire, who's going to come and share some of her experiences with the community pharmacy SPSP pilot for medicines reconciliation, will follow on from my brief introduction of some of my slides. And I think, as David said, this is a pretty honest reflection of where we've succeeded and, to be honest, where we've failed, a reflection on what we might have done differently had we known what we know now. So it's, in some part, it's a story of our journey, and from some of the learning points that have come up from previous WebExes, it feels as though many have had a similar experience. Just trying to move the slide on here. It's not responding. Are we going to move? No. Don't know if somebody can. David, if you can move the slide on for me.
Hi, Ian. It's David here. At the top of the screen, you should see a number 14 and potentially an arrow to the right of that. Yep. If you can click on, there you go.
Got it. Brilliant. Okay, great.
Okay, thank you.
So we'll start again. So we've been involved in all the programs you can see laid out there, and as I said, we've had some success and some what I've determined as not successes. Probably not cover the area of pediatrics either, but we'll pick that up under the acute adult program there. So I thought we would show some data because SPSP is all about data, and I wanted to show a slide that shows some success to begin with. This is a slide of a medicines reconciliation work that we're doing up in Caithness General Hospital in the very north of Highlands, really, in north of Scotland. And you can see that over time things bumped along, a bit of effort went in. We started at that kind of 35% level. We moved it on to 70%, but then it never really got going, and then it fell away again. And this is a hospital that has found it difficult to recruit medical staff, and when it has had medical staff, a bit like the island boards, there's been a lot of use of locum doctors. But you can see I've put an arrow in there that said at a certain point we made a decision to get greater direct pharmacy involvement in the process. We have a relatively consistent, stable pharmacy team in Caithness General Hospital, and really they took responsibility upon themselves to start to make changes and improve things. And you can see now that we're reaching about 80 to 90% reliability across the months. And I think that's really testament to what individuals have done. This is a point I'll come back to towards the end about the use of teams out with the team that we would have normally expected to do this work, which is the medical team. And then an example of what we believe to be a reliable system, and this has always been one of my concerns with SPSP medicines reconciliation, is we've been working at it for what seems like almost a lifetime now, and we've never actually been able to walk away from it and say, we've set up a reliable system, it will keep going, and it's got its own momentum, and we can go away and work on something else. If Toyota was to be working on this, they'd still be trying to fix the wing mirrors onto the car 6 years later, and the wheel rims would still be coming off because they hadn't quite got to that because they hadn't fixed the wing mirrors yet. This is our surgical preoperative assessment clinic data. It's staffed principally by nurses. There's almost no medical or pharmacy input into it. We don't have the resource to put a pharmacist in. Patients are seen in the outpatient clinic by the consultant surgeons, and if a decision is taken that the patients are to attend for an operation in the future, the patient is sent along the corridor to the surgical preoperative assessment clinic. The nurses do all the clerking, they do all the laboratory investigations under protocol, they advise patients what to do in relation to their medicines in terms of timing of taking medicines leading up to surgery, and one of the things they do is they do the medicines reconciliation. It took a wee while to work through that process with them, but actually that was because we probably weren't describing the system terribly well, and once they had grasped that, they teach one another, they support one another, they encourage one another, and you can see that we developed a reliable system going through years around about 2012, 2013. And so then you can see that we actually stepped away from it. We thought, well, there's no point sending somebody down to measure 5 common admission documents that we used, on which we used to undertake medicines reconciliation. There's no point sending somebody to have a look at those because we believe we've got a reliable system. So for a period of about 2 years, we left them to it. And then you can see we sent somebody back in 2015, in August there, and the system over the next 4 or 5 months proved to be as reliable as ever. And that, I think, tells us another story, as we've seen with the pharmacy service up in Caithness General Hospital. It's not actually about the profession the person comes from in terms of the quality of the medicines reconciliation. The key factor appears to be having a consistent group of staff working on it at the same time in a consistent manner and with little turnover, and having a focus on actually doing that work. So that's a real lesson for us, because when we move to the next slide, this is what I'd call a chaotic system. This is where we started. This is our acute medical admissions unit in Regmore Hospital, Ward 6A as was, and you can see that we've put in a lot of investment in effort over time, and fairly early on we got fairly reliable results. We put a huge amount of pharmacy time into this to get this to work, yet we were actually relying on the junior doctors to do the work in the background, and we were there to support them. So what was happening was it wasn't really the junior doctors that were making that, making us look good, if you like, in the early 2010. Actually, it was the pharmacists coming along behind that was, in a consistent way, pushing them along. And then you can see that a few years went by, and we had to withdraw the amount of pharmacy service we could put into those areas, and we didn't have enough time to do all the medicines reconciliation, and you can see performance falls away. There's a real drop-off down into February 2013. And since then, it's been fairly erratic. There's a few dips every August, as we all know, when junior doctors then come into post, but that's not necessarily the case. It's person-dependent. We know that when people are busy, medicines reconciliation gets left behind, and because other tasks take priority. We've done a recent audit of our VTE completion rates for our VTE assessments for patients coming into the hospital, and we can see what's happening there is that staff are getting halfway through the process, and then they're either being taken away from that work, or they reach a point where they have to seek help from somebody else to make a decision, and they never quite get back there. And that's very much the story we're seeing here with the medicines there in our acute medical admissions unit. So again, would we have done this as we did in the past? Well, I think if we could start again, we would do something different. I think what we did was we inherited, if you like, good work that had been going on Tayside, and we just carried on with it, and we didn't really challenge the system. We didn't push back as we probably should have done under Model for Improvement and say, actually, what is it that we need to do in our hospital with the systems we have and the resources we have available to us that would actually help us to achieve what we need to achieve. So the lesson there, I suppose, for me is that slavishly following others doesn't always deliver outcomes. And now I'm going to hand over to Claire Morrison, who's going to share sort of almost another end of the story, which is our work we've done with the community pharmacy pilot. So once I drag the ball, it will be all over to Claire.
Thanks, Ian. I'm Claire Morrison. I'm lead pharmacist for quality improvement at NHS Highland. Over the next few slides, I'm going to talk about our experience of medicines reconciliation and community pharmacy, covering the points on the slides. So what approach did we take in community pharmacy, the process for medicines reconciliation and community pharmacy, how that supports a whole system approach, and some information about the My Medicines wallets. So why community pharmacy? NHS Highland was one of the 4 NHS boards who were selected to be pilot sites for the SPSP Pharmacy in Primary Care pilot over the past 2 years. The first year looking at high-risk medicines and the second year looking at medicines reconciliation. Within the medicines reconciliation work, there was a nationally agreed bundle that all 4 boards tried to implement, and the 4 steps were, first of all, the community pharmacist would reconcile the GP10 prescription with 2 other information sources. So that included the information from the patient, the pharmacy record of medicines dispensed previously, and also a discharge letter as well. Any differences between the discharge letter and the GP10 prescription, the pharmacist would discuss those differences with the prescriber. Any changes to medicines, the pharmacist would spend time talking to the patient about those changes to ensure the patient understood them, and then finally providing counselling to the patient on all their medicines. And so right back at the very beginning, we thought, well, this seems quite straightforward. These are the 4 things we've got to do, and we drew ourselves a little process map, and we did a bit of driver diagrams, and we thought, you know, it'll be fine, no problem at all. How wrong we were. So this is our overall compliance with all 4 elements of the bundle across all of our community pharmacy sites. At the very beginning, we had one pilot site doing a little bit of testing, and it worked pretty well for them. And then we introduced all 5 sites, and you can see that we sat around about 60% compliance. And despite everything that the sites were individually trying, so things like, for example, using stickers to remind themselves to do it, having some staff training, nothing was really working in terms of actually getting up to the high level of compliance we were looking for. So in the summer, in sort of early June, we thought, you know, we actually need to do something different, because just carrying on in this same way, trying to make the small improvements that we're doing just aren't delivering the change that we really need. So we said, well, we should go right back to the beginning and really look at the process and really map out the process properly. And so we did it. And so I kind of think that this is the 9 months later scenario from when we started through to the end. We spent about 4 or 5 months doing some testing, and then we decided we needed to start again. And I'm going to talk through the process map, because it took 5 or 6 attempts to get it right, but now that we've got it right, we actually think we're in a really strong position now to move medicines reconciliation forward in community pharmacy. So the next two slides just break that into two, and we've decided on a two-stage process. The first part is the initial screening. So the first thing that has to happen is the community pharmacy needs to be notified of a discharge by either the GP, the hospital, or the patient, and that can come in a number of formats. And there's a star beside this because I think this is one of the things that we still don't have a system for doing that reliably. Within a pilot scenario, we had a really good setup where our GPs notified individually the community pharmacies of the discharge. I don't think that would be something that could be done at scale. So we do need to think about how that notification could work. But we'll ignore that for the time being, and for the sake of our pilot, we had a good notification system in place. And what the pharmacy then did was, when they received the notification, they maintained a list of patients requiring medicines reconciliation. Really a simple list. We had a form that supported this, and it was so that when the notification was received, it might have been at a really busy time. It might have been when the pharmacist was in the middle of speaking to a patient or doing a big load of dispensing. So they kept a list so that when it was slightly quieter, they could then go and do the MedRec process. So down to the third box, and what the pharmacist has done within Highland is accessing SkyStore to view the discharge letter and comparing the discharge letter with the repeat medicines issued previously, so the record that exists within the community pharmacy. And three situations can result. It could be that there were absolutely no changes to medicines, and actually quite a bulk of discharge letters are like that. So if there were no changes at all, the pharmacist would then make a decision about, is there anything that I'm worried about? And things that might come up here is, even if there were no changes to medicines, if there'd been a significant change to the patient's clinical condition, which might have an ongoing effect on that patient's ability to take the medicines that they're prescribed, then the pharmacist might have needed some action, needed to take some action. But if there was no other concerns, then at this stage they could just say no and sign off that patient, and nothing further would be needed. If we go back to the second scenario, it could have been that there were no changes to long-term medicines, but there were new acute medicines. And in this situation, the pharmacist needed to decide if there was any immediate risk or action needed. And the classic example of this is paracetamol-based painkillers, whereby the pharmacist could see from the patient's repeat record that they were prescribed one paracetamol-based painkiller, perhaps cocodamol, and then they would discharge from hospital with a supply of another paracetamol-based painkiller, perhaps just paracetamol on its own. And where painkillers have got different names, a patient could easily not realise that that both contain paracetamol, and so could be at risk of accidental overdose. So if the pharmacist decided an immediate action was needed, then they would provide that intervention and note it in the pharmacy record, that the details of what intervention had been taken, and then await the next issue of the repeat prescription from the GP. The final scenario is changes to long-term medicines were listed on the IDL. And in this situation, again, the pharmacist would need to decide if any immediate action is needed, and if not, then they would await for the next repeat prescription. The reason that for changes to long-term medicines, it was sensible to await the next repeat prescription from the GP is because when the GP receives the discharge letter, they may well decide we don't want to implement these changes recommended by the hospital because we happen to know that the patient had that medicine 5 years ago and didn't get on with it. And so they may not always, the patient may not always end up on exactly what is written on the IDL, and it would be a deliberate decision to vary from that. So it was best for the community pharmacist to wait to see what the GP decision was, and the way that's communicated from the GP to the community pharmacist is via the next prescription. So at this stage, the pharmacist would have noted down on a MedRec pharmacy record form what actions they were expecting the next time they saw a GP prescription, and then they would just flag their own PMR record with a reminder that they need to do the MedRec the next time they see the prescription. So stage 2, on receipt of the prescription, so the pharmacist would note in the PMR that there is a MedRec to be done. They would take out the MedRec pharmacy record, and then they would consider whether or not the prescription matched the expected changes. If they did, then it's a straightforward process. The pharmacist would dispense the prescription and provide the counselling, remembering in particular that the patient should be aware of any change, is aware of any changes to medicines, and also to find out about any response to changes. So by now the patient will have had several days supply of changed medicines from the hospital. And one of the things that our GP colleagues were really, really keen for us to follow up on in community pharmacy was, if there's been a change, how's the patient getting on? And if there are any problems, can you make sure you feed that back to the GP practice? So at this stage, if the pharmacist had any concerns, they would have taken appropriate action. So it could have been advice, for example, on how to take a medicine more safely, how to avoid side effects, or it could be a decision that needs to be referred to the GP. And again, any actions would be recorded on the pharmacy record. Going back to the top, again, on receipt of the prescription, if the changes on the prescription were not as expected, then at this stage, so if there was a discrepancy between the GP prescription and what the pharmacist was expecting on the IDL, at that stage, they would either look in SkyStore to check the original IDL and any subsequent information that might have led to a difference. And if it was still unclear, the pharmacist would then contact the GP practice to clarify the reason for the discrepancy. At this stage, it could be speaking to the practice staff, who could look up in the GP computer system a reason for medicines to be different. But if there was no reason recorded, then the pharmacist would need to have a discussion with the GP at that stage, and again recording the actions on the pharmacy record. So that's the process that we have reached after quite a lot of work and testing a lot of different scenarios and different ways of doing this. And all of our sites are really comfortable that this process now works for them. And the next step for us is to think about how we solve those problems. So the bits that I highlighted, if I can go backwards, I don't know if I can go backwards, yes I can. So my 2 red stars here at the top, so how we ensure that notification happens is something that we're working on with one GP practice at the moment in terms of looking for an e-health solution to that. And the other part is around how the pharmacist accesses the information, the discharge letter. For the purposes of the pilot, we gave our pharmacists access to SkyStore. A number of other boards are looking at access to information portals. And I think that some work needs to be done probably at a national level about how we grant access to relevant information to community pharmacists. And then finally, we want to, as we move this bundle forward, or we want to just really work out how we, what data we need to collect around our new process map. So I think we might do a little bit of redesigning of the original bundle so that it fits nicely with the new process map we've identified. So a few positive stories. This is from one of our pharmacists involved in the pilot who tweeted that having access to the discharge letter on a bank holiday has been so useful for having really high quality conversations with patients about medicines during times when there is no other way for them to have that access to that information, so the GP practices are closed. And we have a number of examples of where improvements to medicines have been made because of that information. So this slide really just highlights the system approach that we were trying to create, working between the community pharmacist and the GP. So we have the community pharmacist checking the IDL and identifying safety concerns. Meanwhile, the GP is still reviewing the IDL and issuing the GP10 prescription. the GP10 prescription will go to the community pharmacist, where the pharmacist will check it against the IDL and identify any discrepancies, and also provide any follow-up that's been requested by the GP. And then finally, the GP will answer any queries when the pharmacist goes back, or any other concerns, and then the community pharmacist can provide counselling on the medicines. So really the two working together quite well. I also wanted to talk about an innovation that's been developed within the pilot, and that's the My Medicines wallets, and this is a picture of them. If I can move on to the next one, it's got stuck, there we are. So the aim of the My Medicines wallets is to provide somewhere where patients can keep their current repeat prescription lists. So a repeat prescription folded in half and half again tucks really nicely into one half of the wallet. And on the other side, information such as warning cards or details of medicines that have been purchased can fit into the other side of the wallet. And the reason why we wanted to encourage patients to carry this information was we spent some time in our local hospital and discovered that quite often patients didn't have any information about their medicines with them when they were admitted. And so from that, we thought, well, how can we encourage patients to carry that information? And the idea of the wallet was born. So in terms of a patient being admitted to hospital, if they were perhaps too unwell to describe the medicines they were taken, then having a wallet would mean that they could just hand over that information. But we also think that actually there's a much wider use rather than just the hospital. And really that's any health professional who doesn't have access to the patient's medical record could value from having a known place to go to for medicines information. So this is everybody we've thought of so far. So community nurses, out-of-hours service, carers, dentists, a GP if the patient is away from their home and on holiday, for example, a community pharmacist again if the patient's away from home, opticians and ambulance crew. So lots of people who the patient can hand over their medicines information to during a consultation if they feel it would be useful for the health professional in terms of managing their care. The feedback that we've had from the wallets from when we launched them was really positive. So at the moment it's fairly small scale in terms of the number of sites that have got them at the moment, but our pilot site is saying things that patients have been really engaged with them. We had some great Twitter feedback as well, saying, particularly from other professionals, opticians and dentists in particular, saying how useful this information could be. And what we are planning to do starting really very soon, we have a large supply of wallets on order now, and we're hoping to test within a defined geographical area whether or not supplying one to every patient on repeat medicines within a defined geographical area will make an impact on medicines reconciliation on admission to hospital. So from a community pharmacy perspective, I think our successes have been defining the process for medicines reconciliation and working jointly with our GP practices to identify where community pharmacy could really contribute from their point of view, and the development of the My Medicines wallets. Our challenges, as I've highlighted already, are the discharge notifications and how we access discharge letters now our initial pilot has finished. So key points for sharing, I'd say, ask us about our process and about the wallets, and we want to know about the things that are still challenges for us. So the system of notification for hospital admissions and discharges to community pharmacy. And I'll pass the ball back to Ian now.
Thanks, Claire. I really just want to finish off with a couple of slides and a few reflections, and really to praise Claire and all the team who've worked with her for the fact that they've taken the sort of improvement methodology or the spirit of it, and really just gone away and experimented and said, well, it didn't work, we'll have to try something else. And my reflection is this is our run chart for INRs for patients on drug warfarin greater than 6 over the years. And we didn't start with a predetermined plan for how we were going to work on this. We weren't given anything from nationally to do. We were just asked to go away and reduce the rate of INRs. And we've actually, by our own efforts and experimenting, been able to reduce the INRs down such that virtually everyone that's now recorded on the right-hand end of that slide are actually patients who are coming into us on admission in the hospital with a raised INR. So we do need to do some work with the GPs there. But that, for me, really highlights the idea of experimenting, testing, all the things we know from the model of improvement we should be doing, but we don't always do. And I think that's something on my reflection, we should have changed something in acute care and acute admitting wards sooner and just said what we're planning to do just really won't work with a constantly changing workforce in a very dynamic environment. I think reflecting back on what David asked at the very beginning, which boxes have or haven't we ticked? Well, I think in terms of the acute service, we've not really got our systems right. We've not really thought big enough and bold enough about what systems we could introduce that might automate systems or help us with that. And what really concerns me in terms of medicine safety is I've been looking at a program that we're supposedly introducing for insulin for surgical patients who are coming into the hospital where we know we don't do particularly well for diabetics. We're going to introduce some of the same problems we've got in the acute side. We're just going to ask junior doctors to do more and more and give them lots more paper to fill in. I think there's a 10 or 12 page integrated care pathway coming. I'm pretty certain that's not going to work, and our plan is just to say that's it, stick it in, and the reason it's not going to work is because people won't use it, rather than the other way around, which is really that the system's not usable. So my sort of final reflection here is that we need to make sure that we have more folk in the system who actually understand how improvement methodology works, because otherwise we get people with great ideas introducing things that won't work because they haven't introduced them in perhaps the right way. So I'll pass back to Claire for a final summary there, and look forward to what questions you have to ask me and Claire.
Thanks, Ian. The final slide is really just a thank you. These are all the fantastic people involved in the SPSP pharmacy pilot in NHS Highland, and you can't have a presentation from Highland without the appearance of Bertie Brufen, who was our mascot. So that's why he's in every picture, and with a really great bunch of people. So thank you.
Thank you, Claire, and thank you, Ian, very, very much for your presentation. And again, I do want to call out and say thank you for being honest. It's fair to say that a number of boards have probably been challenged, particularly in the acute care setting with MedRec, and perhaps at pilot level there's been some success, but the challenges associated with spread and sustaining that is something that I think others are probably comforted to hear. But I'm also really, really quite impressed with the fact that there's almost seems to be a willingness to potentially start again. So again, thank you both for your time today, and I'm really, really wanting to open things to questions. So Martha, would you mind opening the phone lines, please, just to allow people to speak and ask questions? And while people are coming on, I'm really keen to explore a little bit further with you, Claire, in terms of the process mapping that you did. Were there any surprises or anything that you kind of assumed would be one way, and when you actually started to process map out that there were probably some things that you weren't expecting?
I think one of the biggest learning areas was how we needed to have different processes or different steps depending on whether there were changes to medicines or not. and whether the change was to an acute medicine or so a new short-term medicine or a long-term medicine, and the fact that we needed to split it in half, so that initial screening and then on receipt because of the GP10 prescription, because what we'd said right at the very beginning was that MedRec would happen on receipt of the GP10 prescription, and what our pharmacist said was absolutely not, that it's too late. We need to do that initial screen first, so that we can identify any issues that need to be dealt with right then, rather than waiting for 2 weeks, because it could be up to 2 weeks before the first prescription comes through. And at that stage, you might also have forgotten that you've had that initial notification as well. So, so the two bits, the different scenarios, and the need to do an initial screening and then a second process on receipt of prescription.
Excellent. Thanks for that reflection. So I guess one of the powerful things that you can learn through process mapping is probably ironing out some of the assumptions that people might make about how the system actually works, but when you actually put it on paper, there might be a few surprises, let's say. And I don't want to put people on the spot, but I will. I know that, Andrew, you'd mentioned in the chat box that you use process mapping as part of the work in NHST side. I'm just wondering, are you able to reflect too, were there any things that you weren't expecting or were surprised about when you started mapping out that process of ambulance interacting with the front door?
I think, can you hear me?
Yes, absolutely, loud and clear.
Yep. I think it was what our non-emergency staff have when, with the increasing number of people that they are bringing in for admission, which was, I suppose, it's one of those assumptions. We just sort of focus on that emergency side, and that's where the need is. But when we engaged with our non-emergency colleagues and also the hospital staff, the number of people that were, apologies for that, the number of people that were brought into hospital from the non-emergency, and we were using the green bag, so we opened that out to our non-emergency staff as well.
Brilliant, and thanks for that. And I do hear some what sounds like drilling or something in the background. But so again, can I just put it to the rest of the crew? We've still got a number of people on the call. Are there any questions or reflections or comments you'd like to put to the Highland team today?
Can I ask something to Claire? It was in relation to a statement you made about the process for the informing of the community pharmacy. She felt that, I presume that statement was because the GP process was very person dependent. So have you been able to find a more reliable link to be able to inform the community pharmacy of a discharge?
You're talking about the first step, the notification of the discharge from to the pharmacy, yeah?
Yes.
Yeah. Okay. So within the pilot, it was really quite simple because all of our pharmacies were in remote and rural areas, and so it was a one pharmacy, one GP practice set up. So it was really straightforward. They already have close working relationships, and when the GP practice received a discharge notification, some phoned the pharmacy, some sent a list down to the pharmacy, some emailed the pharmacy. They did it in different ways, but it was the practice reception team who would manage that, so it worked fine. What my concern is if you try and extend that kind of informal model on into a much larger practice that might deal with 7 or 8 community pharmacies, I think a system like that would fall over. So what we're doing at the moment is trying to see if we can create a solution that's more that's got an eHealth backing to it, so a more automated system, but it's in the really early stages of development, so we're not there yet. I think ideally, if you had a system whereby all patients were registered with a community pharmacy, and given that patients are registering for the CMS service, then it's not too big a jump to be registering with a pharmacy, full stop. And then if that data were available somewhere so that the a hospital discharge notification doesn't just go electronically to a GP practice, but it also goes to a community pharmacy at the same time. That would be the ultimate aim.
Excellent, and I do think, thank you for that too. I do think, again, that's a challenge that other boards are trying to work through as well at the moment. So, Claire and Ian, in terms of the spread today, you've been able to share your messages far north as Western Isles and Orkney and as further south as Ayrshire and Arran, as well as having colleagues from the Scottish Ambulance and internal colleagues here at HIS from our Adverse Events Learning team. So it's been great that you've been able to share with such a kind of wide geography of people today. But I think also, to me, one of the reflections I've got is just the potential impact that you've got working within Highland when we're talking about a whole system approach. I mean, you've mentioned such a range of health professionals, including our optic colleagues and dentists, in such a broad kind of medicines management kind of safety framework. So again, I just really wanted to call that out in terms of it's great to see that they're the kinds of people that your improvement work is reaching. I would encourage people to still use the chat box if you'd like to in terms of asking any questions or reflections, but I'm aware of time and we've got 10 minutes left, and we do want to make sure we can top and tail this WebEx appropriately. So please do use the chat box, and I'd want to just use this time to thank Ian and Claire again for the time. But again, this isn't over. We want to make sure that people are aware, and if you can please tell friends. We've got another 3 final WebEx series for the current financial year scheduled, with Lothian next month, Dumfries in January, and Tayside in February. So again, all 4 of these boards, including Highland today, were part of our pilot process at the end of 2015. So it's absolutely fantastic that we've got them now back again, presenting to the whole of Scotland rather than just in that pilot testing phase that we did. So please do make sure that you do join us. The other things that I think we need to make sure people are aware of is the fact that this time in just under 2 weeks, we'll have had the SPSP conference, which we're really looking forward to. For those that are coming along, there's quite a number. The conference itself has attracted 750 people, which actually is now full, and we have a waiting list. So we're really looking forward to having people along. The theme for the conference is focusing on deterioration and how we might look at the prevention, recognition, and response to the harm associated with deterioration. And so from a medicines perspective, we're purposely focusing on omitted medicines and high-risk medicines and how we might prevent the harm that's associated with those, how we might recognize it, and how we might respond. So we're purposely not referring to medicines reconciliation explicitly, but I would say that medicines reconciliation is one key tool that actually would help in trying to prevent the omission of medicines and also the appropriate use of high-risk medicines. So we are definitely not moving away from that topic. So again, the 29th of November, all of the presentations and slide sets for those who unfortunately aren't able to join us will be made available afterwards, but we do look forward to seeing you there. We do want to thank you for your time today. For those, and I know, Andrew, you've been saying as well, that this session has been recorded today and it will be published on our website, so if you do want to direct it to other colleagues, you can share the link off our medicines webpage. But before we go, we've got a question from Sylvia here, and I can see that chat still going. But Sylvia, are you on the line that you want to ask the question verbally? You've talked about practice pharmacists being involved in MedsRec anywhere.
Yeah, can you hear me okay?
Absolutely, yes. Thank you.
It was just really to ask about the role of practice pharmacists in the medicines reconciliation process, and you know, I noticed that Claire's replied to that question, and I've then asked, you know, are they then doing the contact with the pharmacist part of the process as well?
So Claire, do you have a comment on that? Do they liaise directly with the community pharmacies?
So I think so the answer is yes. We've got 2 advanced pharmacist practitioners who are doing MedRec in the practice. What we learned quite quickly when we worked with 2 GP practices around this was they felt that they wanted someone who was there in the practice all the time, who could do the MedRec or effectively take the real lead in doing the MedRec in the practice, and that's the system that we've set up. So the pharmacist is kind of like taking over the GP aspects of MedRec in the practice. So in the same way that the GP would have contacted the community pharmacist if relevant, so too the practice pharmacist would. We don't have a situation anywhere where there's a pharmacist who visits the practice once or twice a month who would be involved in MedRec, just simply because the GP practices said that wasn't going to be useful to them. It would only be useful where the pharmacist was based as a permanent member of the practice team.
Yes, no, that's understandable. The other question I had was just around the IDL, access to SkyStore and the IDL. Presumably patients have been asked for their consent to share information. Was that, how was that done? Was that just a letter that was sent out by the GP practice, or how was that done?
In terms of the access to the discharge letters, we've got a Caldicott Guardian authorisation to enable access to discharge letters. Right,
okay, so that just came purely from the Caldicott Guardian?
Yeah.
And you don't have an individual request to the patient?
No.
No, that's fine. Just wondered about that one. Yeah.
That was specifically written for the purposes of the pilot.
Right, okay. Okay, well, thanks for that.
No, thank you, Sylvia. And I think just to pick up on that point finally before we do go, the information governance, I think, has been identified through this pilot work across 4 boards as a significant potential issue. There's a variation between boards about how information governance is reviewed, and actually the decisions seem to be varied according to each board. So I think you rightly highlighted, Claire, that there's a potential for a national approach to this, to maybe have one approach for Scotland. Which I think may help overcome some of the barriers that some of the boards are facing, which are not insignificant by any means. So again, thank you, Sylvia, for that question. I think it's really relevant. So I'm keen to, again, thank everybody for their time today before we close. For those that are joining us on the 29th of November in Edinburgh, we look forward to seeing you there face-to-face. Otherwise, I hope that you'll join us again in December when we're going to be hearing from Lothian, and then for the other 2 presentations next year. Thank you very much all for your time. It's been great to have you.
Thank you.
Thank you.
Ladies and gentlemen, that concludes today's conference. Thank you for your participation. You may now disconnect. Have a great day.